Title that.
So thank you for inviting me. So we'll start with the talk. So the definition of hyperuricemia is a little bit, the cutoff we are not exact. Every society has their own cutoff. Some society has 6, some have 6.8 and some have 7. So there's no clear-cut definition of the cutoff for hyperuricemia. Hyperuricemia is very, very common in our practice. And in this study, Indian study of over almost 30,000 patients, 25% of them had hyperuricemia. And gout is the most common inflammatory arthritis in men above 50 years, mainly affect males and rarely affects perimenopausal women. So there are various causes of hyperuricemia, but the 3 most common causes, one is metabolic syndrome, then drugs like your diuretics and renal failure. So these are the most common causes of hyperuricemia. Is there any relationship between hyperuricemia and metabolic syndrome? So 23% of metabolic syndrome patients may have gout, but 85% patients of gout may have metabolic syndrome. So this is very, very important. When you get a patient of hyperuricemia or gout, we have to look into this aspect. Look at the sugars, cholesterol, atherosclerotic risk, and obesity. Now, if a patient has very elevated uric acid levels, these are the stages. So initially will be asymptomatic, but then with times we'll have these gout flares, and in between will be normal, which is known as intercritical periods. And if we don't treat these patients, then over a period of time, these gout flares become more common, more often, and the intercritical period reduces, and then develop polyarticular gout and tophaceous gout. Uric acid not only gets deposited into the joints, but can get deposited into other areas, spines, skin, kidneys, eyes, cardiovascular, and multiple other areas. So what is asymptomatic hyperuricemia? So a patient who has elevated uric acid, but no prior gout flares, no subcutaneous tophi. And even if you do an advanced testing like a dual agent CT and you demonstrate these monosodium crystals, but if they had no gout flares and no subcutaneous tophi, still technically they can be labeled as a asymptomatic hyperuricemia. And we have agents to treat uric acid, but should we be using them? Because potentially argument can be that these patients can, from asymptomatic hyperuricemia, can develop gout and all the problems that I had discussed. So I'll give 3 reasons why we don't treat just the uric acid. One is, a patient is asymptomatic and the uric acid is not much elevated, the risk of gout is low. But if it is 9 milligrams or more, then the risk is high. Second reason is that we previously used to give urate lowering therapies to patients of CKD, even with a little borderline elevated uric acid, in the hope that this will prevent a progression of CKD. But the newer studies and data showed that this doesn't help in preventing a progression of CKD. And the third is the adverse effects. So allopurinol can potentially have a hypersensitivity reaction like a Steven Johnson, which has a mortality of almost 20%, though very rare. And febuxostat can cause hepatotoxicity. There is a cardiovascular signal to it. And if we keep treating our patients and keeping the uric acid very, very low, there is an association with neurodegenerative disorders like Parkinson's and dementias. So which are the patients we should be treating? One is presence of gouty tophus and evidence of radiographic erosions. If a patient has 2 or more flares, gout flares a year, or if they have 1 flare and they have stage 3 CKD with or kidney stones or a elevated uric acid of 9 or greater. We don't treat asymptomatic hyperuricemia unless the uric acid level is 9 or more. So does it mean that we don't treat our patients who have hyperuricemia? No, we address the cause, we find the cause. Are these patients obese? And then if they are obese, then we encourage weight loss. Are they on any medicines that are increasing the uric acid, like the diuretics? Do they have hypertension? If they have hypertension, we can give them losartan, which has uricosuric effect. Are they diabetic? We can discuss using SGLT2 inhibitors, again that has a uricosuric effect. Also addressing the diet. So red meat, seafood, alcohol, especially beer, high fructose containing soft drinks, these are all agents which are going to increase the uric acid. So telling them to cut down on these things. A very important thing is that high purine rich vegetables does not increase the risk of gout. So we should not allow vegetarian patients to cut down on the protein intake of their in the vegetarian diet. So the management of gout is 3 parts. One is treating the acute attack, preventing the attack, and urate lowering therapy. So treatment is with NSAIDs and corticosteroids. Colchicine is not anymore used for an acute attack. So there's every hourly dose and till the patient gets loose motion, so that is not given anymore. And IL-1 blockers are not available. So this is the NSAIDs that we can use. Corticosteroids you can use either oral or intramuscular or an intra-articular injection. So anything that not only causes the uric acid to go up, but even come down. So when you start your urate lowering therapy, that potentially can cause a gout episode. So colchicine is very useful, and we give it at 0.5 BD for 6 months or until the tophi resolves. And the most common side effect is the diarrhea. So when we start urate lowering therapy, it is generally lifelong or indefinite. Unless if, for example, if you're a very obese patient and I've undergone a pediatric surgery or now on the newer agents to lose weight, then potentially yes, then they may not need it lifelong. Then the target should be 6 for most patients, less than 6, and less than 5 if they have tophaceous gout or history of urinary stones. Allopurinol is the preferred agent. So we start with 100 milligrams a day and we titrate. The usual 300 milligrams may not be enough to control the disease, and we can go up to maximum we can go up to is 800 milligrams. Adverse effect I discussed regarding the allopurinol hypersensitivity reaction. So we must educate our patient. If they get rashes, they have to stop it and inform. Febuxostat is a preferred agent if they have CKD. So we start at 40 milligrams. Maximum dose is 120 milligrams. Diarrhea, LFT abnormalities are common. Rashes may occur. And I discussed this increased cardiovascular mortality signal in patients of febuxostat compared to allopurinol. If these patients are on azathioprine, then we should not be using these agents. So to conclude, don't treat asymptomatic hyperuricemia with urate lowering therapy unless the uric acid is 9 or more. Treat the underlying causes like metabolic syndrome. Look at the drugs that the patient is taking, and treat if they have gouty tophus, evidence of radiographic erosions, 2 or more gout flares a year, or 1 flare with CKD or kidney stones or uric acid 9 or greater. Urate lowering therapy, allopurinol is preferred. Febuxostat is preferred in CKD patients, and target is less than 6 in most patients, less than 5 in tophaceous gout and kidney stones. Thank you.
Thank you, Puneet.